happens to be mine today. So I will talk about kind of diagnosis of diabetes and resources. It's a little bit of an introductory type of lecture, or session, I should say, that has lots of little things in it that I wanted to do at the beginning. So kind of as we go on with our sessions, we'll be filling in more details about diagnosis and kind of how often we check things and what we do. So I will, okay, and I already introduced myself. I'm a Tulane endocrinology, and so I'll start off with classifications of diabetes. There are 4 classifications. Type 1 is what we usually think of somebody on insulin only. It's an autoimmune disease of pancreas beta cells destruction that leads to absolute insulin deficiency. For these patients, really we use only insulin. I know it's been 100 years since insulin was first discovered, and we still don't have better tools. Delivering them in a pump is the one thing, but actually what we treat with is insulin. There's some other few medications off label, but essentially if you have type 1, you have complete beta cell destruction, you're going to be on diabetes at this point in time. Type 2 diabetes, highlighted here, is due to a progressive pancreas beta cell insulin secretion. So those cells are dying or getting destroyed or damaged, but you still have some of your own insulin. And then this is often in background of insulin resistance. So it's kind of multiple things, but you do still have some insulin being produced. And this echo is going to mostly cover type 2 diabetes. We'll talk about type 1 diabetes as well, but we welcome any cases really in terms of treatment. Type 3 gestational diabetes. So this is diabetes prior to, not having diabetes prior to pregnancy and being diagnosed in 2nd or 3rd trimester. And so this is obviously very high risk because there's a baby involved and so on. Not as common per se for us. We usually see these patients in regular clinics after they've delivered. Mostly GYNs, I think, take care of this, or endocrinologists as well. And then the 4th type is pretty much diabetes from any other cause. It might be medications, it might be a monogenic diabetic diabetes syndrome like MODY or neonatal diabetes. It may be from cystic fibrosis or some other medication or radiation or surgery and so on. So again, we're going to focus on type 2 for the most part. So I did want to cover some statistics about diabetes pretty quickly. So in 2018, and most of this data is from American Diabetes Association, 34 million Americans, which equals to about 10% of population, has diabetes. So when you think about this, 1 in 10 has diabetes. Nearly about 1.6 million Americans have type 1 diabetes. And out of that 34 million, the diagnosed ones are about 26, and then undiagnosed are the other 7. And then the percentage in older or age more than 65, it remains also very high, 26.8%. And then 14.3 million seniors diagnosed or non-diagnosed. As far as new cases, every year we have about 1.5 million. So these are pretty massive numbers. And again, we see these people in our clinics every day, right? So it doesn't matter what kind of clinic you have, you're going to encounter some diabetes patients. So it's good to have at least a little bit of, even if you're not directly taking care of them, just kind of knowing few basics. If they haven't been assessed or kind of pointed in the right direction, anything will help. And then in 2015, statistics show that 88 million Americans age 18 and older had pre-diabetes. And so a large number of these people will get converted to diabetes. And so that 88 million is a pretty scary number. In youth as well, so about 0.25% of population is under age of 20 with diabetes. And then in 2014 to 2015, annual incidence of diagnosed diabetes in youth was about 18,000 with type 1 diabetes, and about almost 6,000 with type 2 diabetes. So these are yearly. We all know cardiovascular disease is #1 leading cause of death in the United States and many other countries in the world. Diabetes is 7th leading cause. So it is pretty high up there. And it is evident by death certificate either mentioning diabetes or actually being a direct cause. So in 2017, diabetes was mentioned as a cause of death in total of 270,000 certificates. So just that alone, those are pretty high numbers again. In terms of, I thought these statistics here were a little bit surprising in terms of the rates of diagnosis by race or ethnicity, kind of going from lower numbers to higher numbers. So non-Hispanic whites seem to be in the lower end, so less than 10%. And then kind of as you go, Asian Americans get higher, Hispanics get higher, non-Hispanic blacks even it increases. And then the highest group is American Indians and Alaskan Natives. But now if you go back up to the Hispanics, Mexican Americans had just about similar rates. So I think some of this needs to be also kind of in the background of our minds when we see patients with diabetes, especially thinking family history or family around these patients. So if we see somebody that's Mexican American and they do have diabetes, again, think not only do they have now family member with diabetes, but they are heart rate to start with. And then, of course, burden of diabetes in Louisiana, this is also from American Diabetes Association. We have nearly about 500,000 people in Louisiana with diagnosed diabetes, and then over 100,000 that have diabetes, they just don't know it yet. So those are the undiagnosed group. And then about 1.2 million or so have prediabetes. And again, I worry about that in a few years if they are going to convert to diabetes, if they don't take kind of appropriate steps. And again, in terms of estimating yearly, about 30,000 people in Louisiana are diagnosed with diabetes every year. And of course, not to mention the financial aspect of this in the red box there. Cost is estimated to be $5.7 billion in Louisiana each year. So for this graph, of course, we're going to focus on type 2 diabetes, but we're going to kind of look at to your left, preventing type 2 diabetes, preventing obesity. What could we do? How do we manage things before we get to diabetes diagnosis? Which some of those things, of course, apply when you do have diabetes. And then on your right, of course, we're going to talk about this even more, managing complications of diabetes. So what can we do to maybe increase insulin resistance? If they have severe beta cell loss, is there anything we could do to kind of rest those beta cells or do whatever it takes to kind of attack it from, yes, you have diabetes, we've got to look kind of back to what happened, what led to this, can we fix, and then forward to prevent issues. And then I wanted to kind of just go over the diagnostic tools. How do we diagnose diabetes? What are we talking about when we say prediabetes? Where are we kind of on scale of things? So if you look at the green boxes here, it says normal. So fasting plasma glucose, which is the first section on your left, normal means less than 100. So if somebody's fasting, we should see glucose less than 100. If they are being tested for whatever reason with a 2-hour plasma glucose during oral glucose tolerance test, normal is less than 140. And then if we're just checking an A1C, normal is less than 5.7. When these numbers start increasing, kind of they're not at the diabetes level yet, but they're in that in-between range, this is what we normally call prediabetes. If you want to call it specifically what's abnormal, you could say if the fasting glucose is abnormal, you could call it impaired fasting glucose. So for example, if the number is somewhere between 100 and 126 and you caught this number on fasting glucose, we could, in terms of diagnosing, billing, and so on, we could call it impaired fasting glucose. It is pre-diabetes state, you could use that as well. Same thing for oral glucose tolerance. If that glucose after the 2 hours is 140 to 200, somewhere in that range, that's considered pre-diabetes. And then hemoglobin A1C, anything between 5.7 and 6.5. The red boxes here, of course, you see is glucose fasting over 126, 2-hour OGTT over 200, and then A1C more than 6.5. And of course, we're going to repeat this number, ideally with the same test that's been abnormal. So you usually need 2 tests to be to diagnose. Otherwise, if you have somebody with symptoms and glucose that's random over 200, that's diagnostic as well. So of course we think about comorbidities with diabetes. A lot of people know many of these. But then there's a few that we normally don't talk about. So on the left, of course, these are pretty common: fatty liver disease, pancreatitis, cognitive impairment, cancer, and so on. On the right-hand side, low testosterone is one that's pretty common for men, obstructive sleep apnea, periodontal disease, psychosocial, emotional things, HIV. So of course, this all needs to be kind of under the umbrella of diabetes that we take care of. And speaking of taking care of, so under that umbrella come the eye, teeth, heart and blood vessel, kidneys, peripheral nervous system, skin, infections, and those sorts of things. So all of those things we keep an eye on, either around diagnosis time or kind of sometimes that gets us to the diagnosis. So it's an umbrella of things that fall under diabetes when it comes to diagnosing, maintaining, following, kind of follow-up. I think this slide is, it's happy news. It's wonderful. We have lots of drugs. I just pulled this from the FDA in the last, I think I picked 10 years. And so you can see how many medications are here. It's pretty hard. I mean, yes, there are only two classes of these, but there's so much out there to treat patients with. And so then you are stuck kind of with, what are the side effects? What do I put them on? What do I start them on? What's contraindication, and so on. So definitely it's a wonderful thing to have this many. It is a little hard to keep up with. And on the next slide, this is kind of my cheat sheet tool that I use. This came from American Association of Clinical Endocrinology. This is their diabetes guidelines from, I think last year, it's 2020. And easy to Google. And this is something I use and I share with my students and residents because, again, there's so much out there. So kind of where do I start? What are the contraindications? So if you look at the very top of this, it gives you the classes of medications. So metformin, GLP-1, SGLT2, and so on. On the left-hand side, it tells you what to look out for. So if they have hypoglycemia, they will tell you which medications are neutral in that sense and which one will cause hypoglycemia. If you're concerned with weight of this patient, it tells you kind of which medications you should be picking. So I think this is a good one to kind of print out, have somewhere, and easily kind of go reference. Big one is, of course, renal disease. So which ones do you adjust? Which ones are good for your kidneys or not, and so on. So this is a good one to have as a reference. So I figured I would kind of make our toolbox with this session so that we could keep these and keep referring to them. Another, of course, kind of document that we go by is Standards of Medical Care in Diabetes by American Diabetes Association, which, by the way, we have our topics for these sessions for ECHO come largely from this document. And it is a pretty large one, 200 some pages, but they are summarized and kind of just gives us A to Z about diabetes, diagnosis, following, what should we be looking at, and so on. So definitely highly recommend this as well. And this is just a front of the 2 slides ago that I showed you. This is the ACE type 2 diabetes management algorithm. So I just wanted to show you what it looks like when you download it. One nice thing that I did find kind of researching around, so the Standards of Medical Care in Diabetes that I just showed you, that's 200 pages, there's actually one that's abridged from primary care providers, and it's wonderful. And it is nicely shrunk to, I want to say, somewhere in the 30-page range. So it's a really nice kind of quick, easy read in sections, and if you just have it printed and kind of go check it out, it's a little quicker. So I thought I would mention it. Googling it easy, it comes up if you just Google the words up there. The other paper that I thought it was really well put together was this update on management of hyperglycemia. It was from 2019 from Europeans and Americans kind of saying, hey, how do we attack this? And I'll show you the next 2 slides, what they recommend and kind of how to go about this. And it's a pretty simple, it's a complicated looking algorithm, but it's pretty simple kind of, I guess, point of this. So on the left-hand side, if you look at patients with diabetes, in the left pink-purple area, you could look at them in terms of complications, cardiovascular, kidney complications, and heart failure. So if you kind of look at that section, then it shows you, hey, maybe for the heart failure patients, we should do SGLT2s, and even for the kidney patients. So this is evidence-based, looking at trials saying, hey, what works well with this population? And then looking on the right-hand side, if these patients don't have heart failure, don't have kidney issues or cardiovascular disease, at least known to us, then you go back to the right-hand side or the yellow, blue, green area, and you kind of start from, okay, what are our goals? Kind of your usual patient. So it kind of separates the two a little bit to make you focus on those cardiovascular outcome trial driven treatments to decrease hospitalizations, decrease heart attacks, stroke, or so on. And the next slide is just a little bit zoomed in, the pink section from what I just mentioned. If you see here, yes, if they do have these cardiovascular things, do they have, is it more of atherosclerosis or is it more heart failure? And that based on those things, you kind of go by benefits again. So again, very nice, I think, kind of algorithms to follow. If you know your patient well, even first visit, you go to this and kind of follow where they're going to get most benefits, keeping, of course, the risks in mind and so on. And then there's another program that I thought I would share with y'all. It's called Diabetes is Primary, and I know I'm a minute over. I should be done in a second here. I think it's a wonderful program, also by American Diabetes Association, and it's a conference on diabetes for kind of geared towards primary care providers. And it's usually a one-day conference on pretty much the topic we're going to cover here, summarized pretty nicely, or condensed, I should say, going from prediabetes to all the way down to patients with complications. So these used to be in person. I think they may have it online, but they're called Diabetes is Primary in case you're interested in a one-day conference focused on diabetes. And I think that hopefully is my last slide. Okay, good. I am done if anybody has any questions. Otherwise, we'll do wrap up and announcements.